This is John Weigel, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here with Dr. John Vetto, one of our CSAP 17 authors, to speak with me today. John, can you share with our audience where you're located, your primary focus of your clinical practice, and maybe a little about how you spend your usual day, if you ever really have one of those?
Thanks, John. Yeah, so I am a surgical oncologist at the Oregon Health and Sciences University in Portland, Oregon. And as you mentioned, I am a CSAP 17 author. I think this is actually my fifth CSAP. And my practice is focused on what's called soft tissue oncology. So I do breast, melanoma, sarcoma mostly. So I help write those questions and other questions for CSAP. I am a professor of surgery, so I instruct and guide the residents and fellows through the OR day. So I typically will operate 2 days a week, go to fairly long clinics 2 days a week, and then on the fifth day, which happens to be Wednesday for me, I will do administrative tasks. I meet with the cancer center staff for various committees. I meet with my data coordinator for large databases we have in the Division of Surgical Oncology. I do formal teaching with the residents, and then oftentimes there's spillover cases or clinic patients that we need to see. So my so-called off day is actually one of my busiest days, but it's a full week.
It's amazing how those off days seem to fill up for all of us.
Oh, yeah, indeed.
Well, thanks for that, and I have asked you to share some of your thoughts about various conditions a surgeon faces concerning topics from CSAP 17 that are located in the breast category. I'm going to lean on you for your breast surgical expertise. So we're going to concentrate on malignant topics. Some of the topics actually come from CSAP 17 questions, and others actually will be from questions that were written but not finally selected for CSAP 17 that I actually have memory of relating to the discussion that the committees had generating them, and I'd want to pick your brain about many of these. And most of them are what a general surgeon may find themselves confronted with in their practice with a patient with breast cancer. So let's get started. Actually, screening always seems a good place to start, and especially with you, John. And so first, when to start, as there still seems to be some discussion over this? What age is appropriate for breast screening to start?
Well, we continue to struggle in the United States with two different recommendations for screening mammography. Over the years, they have come together a little bit. One are the guidelines from the government, the U.S. Preventative Task Force. These are the guidelines that are really set up by Medicare and used by the government to pay for screening. And these guidelines say to start at age 50 and start with yearly screening at that age. And this was recommended in 2009 and hasn't really changed. On the other hand, the American Cancer Society used to recommend starting at age 40, and that was more of an advocacy issue. There was a lot of push from various advocacy groups that screening start earlier. I think over the years, it's been realized that part of that was because it was always known that there were populations of women who had higher risk for breast cancer, and those groups would advocate for earlier screening. But what's now known is that we can do genetic screening, and we'll talk about this later, and find who those women are, screen those women at an earlier age. And so the ACS has realized that when you weed those women out, the general population may not need to start so early. So what they're currently saying, these are their new guidelines that came out this year, is that to start screening at age 40 is now called a choice. The recommendation is to start at age 45. The guidelines are coming together. The U.S. Preventative Task Force says 50. The American Cancer Society is coming down to 45.
Now, you kind of mentioned genetic screening, but are there patient characteristics that change your answer for that?
Yeah, we can talk about gene testing later, but certainly family history, risk. We calculate a Gale model, which we can talk about later, based on a number of factors that would indicate a woman's being at higher risk. Those include whether she's had prior breast biopsies, whether she's had atypia in those biopsies, when she had her first menses, when she had her first pregnancy, the number of primary relatives or first-degree relatives who had breast cancer. And it's increasingly emphasized, and I think CSAP makes this point, that it's really the primary relatives that make a difference. So if you have those kind of things in your history, then you can actually make an argument for going with that earlier age. But we can talk later about actually being a carrier for a gene, which totally changes the screening issues. Before we leave that topic, let's talk about stopping. There's controversy about when to stop as well.
Okay.
And this was brought out in a question in CSAP. The U.S. Preventive Task Force recommends stopping at age 74. So age 74 would be the last mammogram, which is a little ironic because they also note that the highest benefit of mammography is in women between 60 and 69. So they're saying, be sure to get your mammograms up to 60, 69, but when you hit 74, you can stop. The American Cancer Society has never been in favor of stopping guidelines. And they say it's always a decision between the woman and her providers. The new guidelines do say that if you have a life expectancy of 10 years or more, you should continue with screening. And that can be, of course, hard to determine, but I think the way to remember it is the woman's in good health. If a breast cancer would be treated, if it were found, then you should continue screening, and it's more physiology and not chronology. So the American Cancer Society is still not recommending a chronologic cutoff to stop screening, and that continues to be a difference between the two sets of guidelines.
Let me ask you to elaborate on your feeling about that related to colon cancer. So colon cancer, once again, around 70 is the recommendation that screening be stopped, especially if your colonoscopies have never really shown anything. Is there any feeling that if your mammogram year after year after year has been totally negative, is that a patient who it's safer to stop in?
Yeah, I think so. This is a discussion that I have with all my patients as they come up to the U.S. Preventative Task Force age of 74. So every time I see a patient who I'm following in the breast clinic for annual visits, and we do see these patients if there's a difficult exam, if there's a family history, or for whatever reason, and I'm doing annual visits. When I see the patient approach that age, we have this discussion. And if the mammograms have been consistently negative and the exam is getting easier because the patient's getting older and there's less fibrocystic change, then yes, we'll often say, well, let's just stop. This is an issue in a rural state like Oregon, where you've got one big city, and it's sort of cropped up in the corner of the state, by the way, and this huge rural state where people come from sometimes hundreds of miles to see you. In those cases, you also have to take into account socioeconomic factors. How well does a patient travel? How hard is it for them to see you? On the other hand, there are women who they're doing great, and they're in their 70s or at that age, but their performance status is very good. And it's hard for me to recommend stop screening in those women. The issue is a little bit more complicated than the guidelines actually say, because there are women where we've treated them for a early stage breast cancer years before, hopefully cured them. And the question is, when do you stop what's called diagnostic mammography? So if you have a patient who had a breast cancer and you're getting screening mammograms every year, those mammograms are actually called, at least for the first 10 years, diagnostic mammograms. So the question becomes, if you have a woman who's treated, say, in her early to mid-60s, how long do you follow her every year? And I am pretty much coming to the point where if the woman says, I want to follow the U.S. guidelines and stop at 75, and she's, say, 10 years out from her breast cancer's early stage, nothing's happening on the mammogram, nothing's happening on the exam, then I'm actually comfortable stopping screening in those women. It used to be we followed them forever, but we just, I think we're taking it a little bit more selectively now. So Stopping screening on women who have had a history of breast cancer is something I don't really see explicit in the guidelines. It's not covered in CSAP, but it's something for providers to think about.
Well, let me go back to that question regarding the mammography that you mentioned as the test that we use for screening. So I've seen a lot of articles, as well as I can tell you that the CSAP committees had a lot of discussion about the appropriate screening test for a patient with a very dense breast tissue. Have we changed that? Is mammography still the choice?
Yes, we are looking more at density. Density is now recorded actually by a separate BI-RADS score, and this confuses some surgeons, but I would encourage them to look through the entire mammogram report and realize that there's now two BI-RADS readings on the mammogram. The first reading is the BI-RADS score that we're used to. Of course, BI-RADS stands for Breast Imaging Reporting and Data System Reading. And the mammogram will have the first BI-RADS, which is a risk of malignancy. And that hasn't changed, and that still goes from 0 to 6. And that will typically be at the top or the bottom of the report. But then, at least in our reports, at the bottom, there's a separate new BI-RADS score, and it's a different system. It's a 4-point BI-RADS score, and it reports on the density of the breast tissue. And there are 4 categories, and there is a question on this actually in CSAP Advanced that goes into this kind of detail. But the 4 categories are BI-RADS 1 is almost entirely fat, 2 is scattered fibroglandular density, 3 is heterogeneously dense, and 4 is extremely dense. And those last 2 are called dense. And density reporting is mandated by several states now, which is important because density does increase the risk for breast cancer. And I can come back to that when we talk about other risk factors. But it's an independent factor for breast cancer. Density reporting is mandated, as I say, by several states. It probably will become nationally mandated soon, which is a little ironic because it's highly variable. Density reporting can vary from radiologist to radiologist and center to center. So the efforts now are to sort of automate density reporting with something called volumetric assessment. So in the future, I hope that density reporting becomes better and more standardized. But the issue is how to image people who have dense tissue or what to make of it. So that has led to a change in what modalities we use for screening.
So in your institution, what happens with that dense breast or that patient with that dense breast?
Yeah, there's 2 possibilities. It used to be that if you had a mammogram, remember, mammography is a great test. It's actually a great test because it does what you want to do. It gets better with age. And as we said, the U.S. Preventive Task Force and the American Cancer Society recommend that we start screening and continue screening up to the point during a woman's life when she has density in the breast actually goes down. So as you're screening her with mammography, breast density decreases, mammography gets better. But mammography across the board will still miss 15% of cancers, largely because they were either lobular and not as well seen or because the tissue was dense. So it used to be that MRI was the go-to because MRI is not really affected by breast density, but MRI is expensive, it requires contrast, there can be allergic reactions, some people are claustrophobic and don't tolerate it well, so there are issues with MRI. The new kid on the block is tomography. Tomography, the way it's done is you start with a screening mammogram. If the tissue looks dense, then we'll go to tomograms. Tomograms are kind of our go-to for denser patients. They're done, if you remember the old pulmonary tomograms, that's the sort of before chest CT, for those of us who are kind of older. But remember, you used to get all these images they would sort of shake the patient back and forth and get multiple views through the chest. Well, breast tomography works the same way. It's all done digitally, so there's less radiation exposure, and you end up with all these images instead of just the typical 4-view mammograms, 2 on the left, 2 on the right. We actually end up with lots of images, and then they can be fused to create a 3D picture. And tomography in our institution is indicated for these dense patients with these BI-RADS 3 and 4 density categories, and for people who are at higher risk. So especially if you have that combination where you have some family history or you've had LCIS or some other thing that raises your Gale risk, plus you have dense tissue, we will go to tomography. I have actually been ordering more and more just tomography right off the bat, but typically our radiologist will start with a 2-view or 4-view film and then go and do the tomography if they think it would be a benefit. Ultrasound is another test that sometimes comes up, but it's still not considered a primary screening tool. It's more considered a secondary tool, particularly if there's something focal on the imaging of the exam that you want to look at with a point-specific test.
Okay, now you've already mentioned risk factors and you've already mentioned the Gale model. Is this standard when you see a new patient that you're gonna go through a list of risk factors and do a calculation of her Gale score?
Yeah, it is. We do that. I do that on all the new patients or on patients who come to us for screening because they're concerned that they might be at higher risk. And I mentioned that we see patients in the clinic there where we do the screening because of issues. The risk factors, I think I want to stress to the general surgeons that the biggest risk factor for breast cancer is still age. And that's what the guidelines are really getting at. Age is still the risk factor. Most breast cancers are still occurring in the late 50s and in the 60s. We always notice premenopausal cancers, but they're still less common. The second risk factor that is sort of popped up over the last few years is obesity. It's now recognized that there's a direct relationship between BMI and breast cancer risk, and that relationship is actually associated with an increase in the tumor size, the chance that there's tumor in the nodes, and metastatic risk. It's all associated directly with BMI. It's not known whether that's just a surrogate for diet or exercise or what that's about, because there's no evidence that if you lose weight, that your risk goes down. There's a question on this in CSAP where they emphasize the risk of obesity. The other risks that we all know about are the so-called estrogen window. I like to think of it as the risk from estrogen exposure is like a window. So anything that enlarges a window enlarges a risk. Anything that shrinks a window shrinks a risk. So if you have an early menarche, if you have a late menopause, if you have no pregnancies in between, so there's no opposed progesterone, then the window enlarges and your risk increases. If you have late menopause and early menarche, and you're not taking any exogenous hormones, and you have some pregnancies in there that decrease pure estrogen exposure, then the window shrinks. So I like to think of that because I think a lot of general surgeons try to memorize all those risk factors. Just think of it as a window of time when you're exposed to estrogen. So the estrogen window is still on the risk factor list, and of course family history is on there. But again, we emphasize that it's primary relatives only that really increase the risk. Another thing that came up in CSAP was the effect of race. And this has been sort of a controversial topic over the last few years, whether race affects risk. And the data seems to say that there's no increased risk for breast cancer from race, but race does affect, unfortunately, the stage of presentation. So women of color seem to be at a higher risk for a later stage when they're diagnosed. So they don't have a higher risk, but they have a higher risk of being at a later stage. And they also have a higher risk of what are called triple negative cancers, and we can talk later what those are, but those are biologically more aggressive cancers. So when you look at inequalities between white and non-white women who are diagnosed with breast cancer, non-white women have higher stage, and that's probably an access inequality issue. But they also have worse cancers, and that's more biology issue. That's not so much an access issue. So non-white women are sort of at kind of a double risk for having higher risk biology and later stage diagnosis, but not per se a higher risk of cancer overall.
I have two more screening questions for you. The first is with the number of prostheses that we're seeing as patients decide what they're going to do with either early-stage breast cancer or prophylactic mastectomy, does that affect the accuracy of screening for that patient's future?
No, this wasn't covered in CSAP. I think this was covered a couple of CSAPs ago, but technically we just get what's called the pinchback view, where the prosthesis is actually held back by the patient or the technician. It can actually be pulled back depending on how it was put in. That's why we encourage them to be put in below the muscle. They slide along the chest wall easier and can actually be pulled back. And one of the benefits of tomography is you can actually get very good views around the capsule of the implant by getting multiple cuts. And so generally they don't reduce the accuracy of imaging. One thing I forgot to mention was indications for MRI. Because we have tomography, we used to be, if you had dense tissue, you got defaulted into MRI. MRI, as I said, has some limitations. Tomography has come along to alleviate some of those, but there's still indications for MRI. There's a question on this on CSAP. So there's a question on tomography. There's a couple questions on when to use MRI, and I think general surgeons need to know this. Because mammography can miss 15% of cancer, and because MRI isn't affected by density and has a higher sensitivity, it's a good go-to test, but it does have the issues I spoke of. So the American Cancer Society has actually come out with 4 recommendations for MRI. And this is a question on CSAP, and they are patients who carry BRCA mutations, patients who are untested but have a primary relative with a BRCA mutation. And remember, BRCA mutations are autosomal dominant. So if you have a primary relative with a BRCA mutation, you have a 50% chance of carrying that mutation. So those patients are included. Any woman who has a Gale risk of greater than 20%. And I didn't really answer your question on Gale, but I do use the risk factors we talked about to calculate the risk. The new term for Gale risk, by the way, is Breast Cancer Risk Assessment Tool. That's actually the right name for it now. And it calculates the risk at 5 years and the risk for lifetime. And anyway, anyone with a lifetime breast cancer risk assessment tool, risk of greater than 20% would be the third category for the ACS recommendations for MRI. And the fourth would be any woman who's had mantle radiation for lymphoma. We're seeing fewer and fewer of those patients, but we still see patients where they've had mantle radiation, the breasts were exposed, and those patients are at very high risk for breast cancer. So BRCA carriage, untested patients who have a primary relative with BRCA carriage, women with a breast cancer risk assessment tool, a risk of greater than 20%, and mantle radiation are the 4 typical recommendations for MRI.
And as the technology has advanced, do we have a problem with overdiagnosis?
The issue with overdiagnosis is mostly the issue of DCIS. As women live longer and the screening gets better, and as more women follow screening guidelines, we're finding more ductal carcinoma in situ, or DCIS. And DCIS now makes up about half of all screen-detected breast cancers. And in the last few years, as we all know, there's been an issue with, are we finding and treating too much DCIS? There is a question on this in CSAP Advanced, not in CSAP 17, but it's something I think general surgeons need to be aware of because it's something that always comes up in discussion with patients, especially older patients. The issue with DCIS is that what we believe is that 25 to 50% will progress to invasive duct cancer if left alone. So the goal with DCIS is sort of twofold. One is not to overtreat it, but on the other hand, the goal is to get local control so it doesn't progress to invasive breast cancer. Obviously, that's going to depend on 2 things, a woman's age and performance status, and secondly, on what kind of DCIS we're dealing with. I sort of more in the old days when we used to use a Van Nuys prognostic index, or what was called the VPNI. This was a tool that came out of the Van Nuys Breast Center. We used to use it regularly. It looked at the grade the margins on excision and the size of the DCIS, gave it a score, and the newer VNPI also included the woman's age. And you got either 1, 2, or 3 points for those 4 things, so you could have a score between 4 and 12. And the whole recommendations were if you were lower on the VNPI, you could probably not do anything more. If you were high on the VNPI, those were the women that you would think about mastectomy, and the women in the middle, you'd think about adding radiation to a lumpectomy. The trouble with that score, it was always criticized because those recommendations and the score itself were based on retrospective data, a lot of it, but retrospective data. So along comes the NSABP, and they do a couple of very large studies that are prospective, level 1 data, and they sort of made us think that one size fits all, that you need to treat all DCIS with lumpectomy radiation, and you need to give hormonal therapy for the vast majority, since the vast majority of DCIS is hormone receptor positive. So I think what happened was we got away from the VNPI, and we got into the NSABP, and we sort of ended up at these blanket recommendations for DCIS, started thinking about DCIS as one thing. So I think if we want to get away from overdiagnosis, the way to do it is to start really looking at what kind of DCIS have we got, who's the patient, how old is she, what's her performance status. And this, of course, dovetails with the issue of when to stop looking, which we have already discussed. There is a question in CSAP Advanced on what are the things that should make you worry about DCIS. And the answers to that, I'll give away the answers to that, are if you have margins of less than 2 millimeters, and we'll talk about that when we talk about margins. If you have chemotonecrosis, if there's high grade, a large size of DCIS, and if you have a younger patient. And we're really getting back to the VNPI, because those were the things we looked at. How big is the DCIS? What's the grade of the tumor? What kind of margins did we get? Those were all the things that were in the VNPI. Now we have some genetic tools to help us. We have a genetic expression profile, or what's called a GEP test, which we can talk about later. There's one specifically for DCIS called Oncotype DX DCIS. It's made up of 12 of the 21 genes in the Oncotype DX, which we can also talk about. And there are prognostic markers that the pathologist can look at. They can actually look at the DCIS and give the surgeon an idea of how worried to be or not worried to be about the DCIS. And that is, they will look at ERPR, which are positive markers. Those are good things. The Ki67, which is a bad thing, and whether there have been deletions in P16, P53, which are tumor suppressor genes, ERB2, COX2, other genes like that. We haven't gone back to the VNPI. Instead, we're going to genetic markers for risk or non-risk with DCIS. So rather than have the general population get mad at us because we're overdiagnosing DCIS, I think it's up to us to use our medical knowledge to be smarter and to look at the DCIS and then tell the woman exactly what kind of DCIS she has and whether we're about to overtreat it or whether we're going to undertreat it if we don't move on this particular lesion.
So we're getting smarter.
We're getting smarter slowly.
Okay.
Eventually.
Let me jump to, you introduced it, and I think it's a great transition. So let's talk about margins, and especially margins for breast conservation surgery. So isn't the general surgeon confused that invasive breast cancer needs a margin of no tumor on ink, and DCIS, the one we just talked about, needs a margin of 2 millimeters? That seems counterintuitive.
It does indeed. And I think that there is a good explanation.
Oh, I'd love to hear it.
What you're referring to, of course, is the new guidelines that came out in 2016. And these guidelines were really a godsend, because I actually wrote a question in CSAP 16 about margins, and one of the knowledge pieces of that question was that there was, at the time, was a 20 to 40% likelihood of having to go back and re-excise margins after lumpectomy. And I think a lot of general surgeons were loath to do lumpectomy because they were afraid they'd be having to go back and do repeated operations. I do have patients where we've gone back as many as 3 or 4 times to re-excise margins back with the old, before we had the new guidelines. So the question on CSAP 16 was about re-excising margins and how to maybe lower that re-excision risk. But now the guidelines have sort of made that better. So in 2016, the guidelines came out they were joint guidelines from the Society of Surgical Oncology, the American Society of Radiation Oncology, and the American Society of Clinical Oncology. And they are exactly what you say. They were based, by the way, on 33 trials. So it's a very large meta-analysis, very good guidelines. And what they said was no tumor on ink was adequate for invasive, but you had to be at least 2 millimeters away from DCIS. And the two reasons for that are, number one, remember with DCIS, the goal is to prevent recurrence, because recurrence, between 20 and 50% of the time, recurrence of DCIS is invasive. So when DCIS is allowed to recur from an inadequate margin, you're suddenly introducing a death rate. Because remember, DCIS is a disease we really should cure. But if you don't achieve adequate margins, then you suddenly are introducing mortality, because suddenly you've got invasive cancer. So that would be a failure of the goal, which is to prevent recurrence. That's where the goal for treatment of DCIS. So that's one issue. The other thing is that DCIS, unlike invasive cancer, can have skip areas. So pathology studies show that the re-excision margins for DCIS will often contain little skip satellites of tumor. So for those two reasons, that's the reason for the 2 millimeter guideline. I will say that the studies have looked at larger than 2 millimeters, and they don't seem to show, once you get out to 2.5 millimeters, they don't seem to really make a difference. So that's sort of where that guideline came from. And again, that was from a large meta-analysis. The guidelines say, when you look at the guidelines, they actually say that if you do have less than 2 millimeters, what are you supposed to do? And the guidelines say, and this is a direct quote, use your clinical judgment. Well, what does that mean? It means that if I see a woman who's had a lumpectomy for invasive cancer, but then we discover on the final lumpectomy that there was surrounding DCIS and we're nicely away from the invasive component, but there's DCIS within 2 millimeters at this margin or that margin, then I'll discuss it with the radiation oncologist, and we'll see how comfortable they are. They can sometimes run a Oncotype DX DCIS, the test I mentioned, the genetic expression profile that I mentioned. But remember, that test is based on negative margins. So particularly if the test shows low risk for recurrence and suggests that you can omit radiation, then I might go back and actually excise it just so that I can know that this woman's meets guidelines, because we're not going to give her radiation, so I'm not going to get any additional help from radiation. Sometimes, on the other hand, the radiation therapist says, well, we're going to radiate her anyway, and the margin, 1 to 2, probably doesn't make a whole lot of difference. So gets back to the main issue about oncology nowadays. It really is a team sport, and it really does help to talk to your colleagues and get their opinion so that everybody agrees, particularly so that the patient's not hearing different things from different providers, which is always stressful for any cancer patient.
Yeah, how true for anything that we do. So, all right, well then let's ask another question regarding breast-conserving surgery then. Is that now the standard operation used to treat breast cancer in general?
Yeah, I wouldn't say so. I think we got in trouble years ago. In fact, there was a director of the NCI years ago who got in trouble with this and eventually was replaced over some things that were said. And one of them was a blanket statement that came out from the NCI at that time saying that breast conservation was preferred. And I think that was an overstatement then. It's an overstatement now. It is definitely a choice that is a good choice and always needs to be brought up with any woman. Some women come in and say, I just want my breast removed. I don't want this. I don't want that. And I will always send that woman to the radiation therapist on one hand and to the plastic surgeon on the other so that she knows what she's getting into. I'll also always stress that under the non-Halstedian thinking that prognosis of breast cancer is run by metastatic disease and not local failure, that the choice she makes between breast conservation and mastectomy will not affect her survival. So, yes, we are I like to use, whenever I think the patient's is technically a good candidate for breast preservation or breast conservation, I will discuss it and recommend it as a technician, but then we'll make the decision based on her goals, her performance status, her ability to undergo a bigger operation or not undergo a bigger operation, all those things. It's a long discussion, but it's a forever discussion, so it's an important one. But the point is that we are doing more breast preservation. By the way, I want to make a grammatical note.
Okay.
The original term, if you look way back at the original literature from the NSABP, the original term was breast preservation, not breast conservation, but somehow through advocacy groups and common use of the term became BCT, or breast conservation therapy. I like the term breast preservation. That's a term we actually use here at Oregon, but I think we're in the minority. We call it BPT. The reason I like breast preservation is that's what you're doing. You're preserving the breast mound. The reason I don't like the term breast conservation is it sounds like you're doing less. It sounds conservative. Oh, you're doing less. But actually, breast conservation is, in some ways, it's more. You have to have the lumpectomy. You still have to have the general anesthesia. You're still going to get the sentinel node biopsy. You may need a re-excision margins, as we just talked about. You're going to need 3 to 6 weeks of radiation, unless you have intraoperative radiation, which is of limited utility. So I stress to women that it's a commitment, and it's a package deal. You have to sort of understand that we're unbundling the goals of local therapy, whereas mastectomy sort of achieves them all at once, assuming you don't need post-mastectomy radiation, of course. So I prefer the term breast preservation, so forgive me if I keep slipping.
Okay.
But at any rate, the point is we are seeing more breast preservation because we're finding cancers earlier. There are now been studies come out from the radiation literature that you can actually do 2 lumpectomies and still radiate the breast with low recurrence rates. We participated in that study a few years ago. That was a positive study. And we'll talk about it later, but now we're using neoadjuvant chemotherapy to downsize tumors and make more patients eligible for breast preservation. But it's important to stress that there are still mastectomies hanging in there. It's still an operation that we recommend. And the remaining indications for mastectomy, and there's a question on this in CSAP Advanced, is multicentricity, so having multiple tumors in multiple quadrants. As I said, we have prospective data that 2 lumpectomies are safe, but after that it gets sort of ridiculous. If you have multiple cancers, either you should just go ahead and do a mastectomy. If you do the neoadjuvant therapy, but the tumor doesn't significantly shrink or doesn't shrink off of vital structures, in other words, if it didn't downsize enough. So not everybody who starts neoadjuvant chemotherapy shrinks enough to get lumpectomy. If you're doing risk reduction, so as we're screening more women, we're finding more carriage of BRCA and other genes, and those women are ideal candidates for bilateral risk, what's now called risk reduction mastectomy. If the patient doesn't want radiation, if she can't get to a radiation center, this is a rural state, and traveling to radiation centers is still problematic for some women. If they refuse radiation, if they're contraindicated for radiation because of various skin or rheumatic or autoimmune diseases, if they have a central location and the nipple's involved anyway and they're going to lose their nipple and need a large central lumpectomy, they may actually look better with a reconstruction. If they have a local recurrence after breast preservation, that's more of a relative risk. We are now salvaging more, particularly older women who have a limited local recurrence with a redo lumpectomy, and I'm glad to see that. If they have extensive DCIS, I had a patient from an African nation who came to the clinic, and she had large pendulous breasts, and she had her first screening mammogram I think she was in her 50s, and she had extensive calcifications that ran from her chest wall all the way to her nipple and sort of filled about at least a third of the volume of her breast. And a biopsy of that showed intermediate grade DCIS. Well, you can't do lumpectomy on that. So we had to get the plastic surgeons involved. We had to do mastectomy reconstruction on one side and then reduce the other side and do a mastopexy on the other side so that she'd have more symmetry. And again, that was definitely not overdiagnosis of DCIS because she had intermediate grade, she had large size, she was a young person. She had all the reasons on the VNPI to get this out, because if it recurred, it was going to be a high risk for giving her an actual death risk. So we had to do the right thing. So my point's a simple one. There are a lot of remaining indications for mastectomy.
you threw in that sentinel lymph node biopsy was part of the treatment with breast preservation. And so is it essential for every patient now with breast preservation to have a sentinel lymph node biopsy?
Yeah, no, not at all. I'll say this. We're actually going in different directions with sentinel node biopsy. On the one hand, there's now a national organization of data review and guideline that's been endorsed by the Society of Surgical Oncology called Choosing Wisely. And in June of this year, they came out with a new recommendation, and the recommendation is that sentinel node is not routine for women older than 70 who have early stage luminal A, which means ER positive, HER2 negative, so good prognosis, invasive breast cancer. So you have an older woman with a good prognosis cancer, which is and those cancers are more common in women as they age. And what the guideline is based on the fact that most of those women are going to get hormone therapy anyway. So sentinel node biopsy doesn't really change the recommendations for treatment. It really doesn't affect local recurrence or survival. So that's the new Choosing Wisely guideline. So on one hand, we're getting away from sentinel node biopsy in older women. One of the controversies has always been whether you do it for DCIS. There have been editorials that have come out that just said it's unnecessary and morbid, and DCIS. Those are actually words you see in the titles of these editorials saying we should not be doing sentinel node biopsy for DCIS. I'm a little old-fashioned. I still think about it in high-grade extensive DCIS. I did a sentinel node biopsy on that patient I mentioned. It was negative, fortunately. The SSO Choosing Wisely guidelines, which have actually been out for a couple years now on this issue, say that it's not routine in DCIS. There was a large Dutch study that showed sort of what we all believe is that positive sentinel nodes occur in DCIS across the board about 3.5% of the time. So it's not wrong to add it for high-risk DCIS, higher if you are still doing VNPIs, for example, and you calculate a high VNPI, I would probably consider it, but that might put me in the minority. So we're getting away from sentinel node in DCIS. We're getting away from sentinel node in older women. On the other hand, we're starting to think about it, and I never thought I'd see this, but this is something that came up in there's a statement in CSAP 17 on when to not do sentinel node, and it says you don't do it for macroscopic disease. In other words, if the woman presents with a palpable node and you do an FNA or a node that's seen on ultrasound is suspicious, you do an FNA, it's positive, well, that's macroscopic disease. You're not going to do a sentinel. We're beyond the point of sentinel node biopsy. But what's actually happening now, and so that point is made in CSAP 17 is absolutely correct. But in CSAP Advanced, we make the further point that what's actually happening now is that we are now treating women with macroscopic, upfront, known nodal metastases with neoadjuvant chemotherapy. And a certain percent of those patients, those nodes are melting away. And now we're left at the end of the chemotherapy with a patient who presents for surgery and has no palpable nodal disease. So she has what's called a complete clinical response. The question is, can you do sentinel node on those patients? And I recently wrote an editorial on this topic, commenting on a study that was published on one of these neoadjuvant trials. And indeed, I think that the next generation of adjuvant trials will look at whether we can do sentinel node biopsy, and if the sentinel node is negative, whether we can actually not do the completion dissection we always thought we had to do for palpable disease. So we're entering a new era where we will do less sentinel node for older women than for women with DCIS, and maybe start thinking about doing sentinel node on women who initially presented with palpable disease. It's a paradigm shift.
Well, I'm going to get to that editorial here in a little bit, but I'm going to introduce it with a question. I understand what you just said, but is there a move to not do any axillary dissection in some patients with positive nodes?
Yeah, I think that this move started, of course, with the Z11 trial, which sort of took a lot of general surgeons back, and myself as well. But I've come to grips with that trial. That was a trial, of course, where women were randomized to get or not get an axillary dissection for a positive sentinel node. And It has to be stressed that that trial was limited to early-stage cancer, no more than 3 nodes positive, had to be microscopic, true sentinel node, true positive sentinel nodes, and they had to be getting radiation. So it excluded neoadjuvant patients, it excluded mastectomy patients. But what that trial showed was that there was no survival advantage for axillary dissection. In fact, what it showed was that even though we know that if you complete the dissection, you find that in that trial, for example, there was so-called non-sentinel disease, meaning tumor in the rest of the remaining nodes, the nodes that weren't the sentinel nodes, in 27% of patients, which is high. But when you didn't do the operation, you didn't get 27% axillary failure. What you got was a couple percent. And the difference is, I think, twofold. One is a lot of those women got radiation and axillary radiation fields. And so there's a role for radiating the non-sentinel nodes instead of taking them out. And that role has increased over the years, and that decreases the role for X-ray dissection. And the second thing is I think there's a different biology for breast. I always compare it to melanoma. So, for example, there's got to be a biologic difference where you've got 27% of nodes with tumor in them, but only a couple percent grow up and cause failure in the axilla. So yes, some of that's probably due to radiation, but I think some of it's due to just a biologic difference. And it's also due to a lot of the fact that a lot of those women get adjuvant therapy, either hormonal, chemo, or both. And that's also operative. In melanoma, there's a different biology. So in melanoma, there was recently a trial, and I bring this up because I don't want general surgeons to miss this point. In melanoma, there was recently a trial called the MSLT2 trial, where it was a similar trial. Melanoma patients with a positive sentinel node were randomized to get or not get the completion dissection. There was no difference in overall survival, but again, similar to breast, 24% of patients had remaining tumor in the non-sentinel nodes, and in that trial, 24% failed. We don't radiate them, we don't always get them adjuvant therapy, and I think there's a biologic difference that melanoma in sentinel nodes persists and progresses, whereas breast cancer in non-sentinel nodes doesn't always do that. So for those reasons, I think in breast cancer, we're getting away from axillary dissection, and the holdout was always patients who didn't fit the Z11, who were getting neoadjuvant chemo, who were getting mastectomy. But there have since been trials in mastectomy patients, and I mean not getting post-mastectomy radiation, and results from those trials are pending, but I think they'll also show there's low axillary failure rates because of this biologic difference I'm talking about. And now, as I mentioned, with neoadjuvant chemotherapy, if we can make the axilla clinically a complete response, we can then use sentinel node and then apply the Z11 concept. As I say, we're getting away more and more from axillary dissection. It's not an operation I never do because I still see patients who are referred to me specifically as a tertiary provider who have indication for axillary dissection because of different biologies or failure. They actually are the patients who failed in the axilla, that 1 or 2% get sent to me. So I'm still doing the operation, but not as much as I used to.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.
Now, one of the fears we all had when we were doing axillary dissection was lymphedema, and I think your editorial is related to lymphedema and what actually is the cause. You want to elaborate?
Yeah, so that editorial, I was commenting on a study that was just published in JAMA Surgery, and it was a study of the Z1071 trial. You can see how far we've gone from the Z11, but this is one of the so-called alliance trials, and these are cooperative group trials, and this particular trial was looking at neoadjuvant chemo, was comparing different regimens for neoadjuvant chemo. But in this trial, the results of that trial had been previously published. It sort of showed which regimens were best. But this was a side analysis of the trial's separate paper discussing lymphedema. And what that showed is that the lymphedema rates were very high. 58% had lymphedema, which is high, from either volumetric measurements or a validated questionnaire. And so what I said in the editorial was two things. One is, of course they had lymphedema, because everybody got radiated, everybody got an axillary dissection, and everybody got one form of chemotherapy or another. And the other thing I said is that, in the good old Halstedian days when women got mastectomy and no adjuvant therapy, where the surgeon was the only person responsible for lymphedema because they were the only person involved in the care. Now that this is a team sport and we have multimodality therapy, everybody's responsible for lymphedema. In fact, the title was actually not just the surgeon's fault. And I meant the instructions for JAMA surgery was to give it a punchy title, so I gave it that title. But at any rate, it's true. Medical oncologists cause lymphedema because there are some regimens that seem to cause more lymphedema than others. What that trial showed was the longer you got chemotherapy, the more lymphedema you got, and that may be a surrogate for extent of disease or performance status. The trial also showed that the lymphedema was related to BMI, which we already know that higher BMI is a risk factor for lymphedema. We're often hesitant to discuss that with patients because we don't want to blame women who are going through difficult cancer therapy, but I think there's a role for, frankly, telling women about the data and encouraging them to eat healthy and maintain a healthier weight. And I have actually seen lymphedema get better. In some cases, actually go away if I can get the patient to work with us and get herself back to a healthier baseline weight. So I think that needs to be discussed. So the other person, of course, who remains responsible for lymphedema is the surgeon because we're still doing axillary dissections. And I'd like to see, again, this trend with the newer trials where I actually look at using radiation instead of axillary dissection if the sentinel node is still positive. And the other person responsible for lymphedema is, of course, the radiation therapist. And there's ways to limit that. So the editorial goes into the fact that surgeons, radiation oncologists, medical oncologists, and the patient all contribute to lymphedema and can all contribute to making it less.
Let me refer back to your introduction, John, where you said, well, I'm at a teaching institution, and that's been my career as well. So there was a recent article regarding, and to be very honest with you, it caught my attention because I'd never thought of this problem. But what it states, it's from Duke, and what it states is that the number of mastectomies and axillary lymph node dissections that surgical residents are reporting are diminishing almost to non-existence. And I guess if axillary lymph node dissection stays in our regimen and mastectomy stays in our regimen, have you thought about this as a problem? I mean, we've talked about it in open vascular cases. We've talked about it in open trauma cases. But this is the first time I've seen anything regarding axillary lymph node dissections and mastectomy come up. And like I said, it caught my attention immediately.
Yeah, no, I know exactly what the article you're talking about. And my thoughts on that were, we sort of already discussed this a little bit. It's going to be institutional. It's going to be vary from place to place, how hard you're pushing breast preservation or breast conservation. We are now swinging away from this trend, and I think what this article caught was the end of a new pendulum swing, so that, as you know, a few years back, there was a big push for prophylactic mastectomy, and we can talk about this. And that was with the Angelina Jolie thing, where you had a celebrity, and there were some other celebrities who followed suit who got bilateral mastectomies for risk reduction, and so there was suddenly a big uptick in prophylactic mastectomy, and everybody wanted it. And women were coming and discussing with me, and I was explaining that for average-risk patients, there's really no survival advantage. I calculate maybe a 1 or 2% survival advantage. There's a CSAP 17 makes a point that it's essentially zero to have a contralateral prophylactic mastectomy. So we are, as I mentioned a moment, although there's still indications for mastectomy, we are moving away from that. We are pushing more breast preservation. And then with the Z11 trial, we're doing less axillary dissections. So fewer and fewer of our trainees are really learning how to do these operations. And what that means is that people like me can never retire because, I know, for better or worse, how to do some of these more difficult X-ray dissections. I had to do one the other day in a patient who recurred in level 3, which are the nodes medial to the pectoralis minor muscle, and are very difficult to get to. I had a patient at an isolated level 3 node, which I actually approached through the chest. I actually went anteriorly and split the pectoralis muscle and got to the node that way, peeling it off of the axillary neurovascular structures. And this other woman, I went through a standard dissection and just got down immediately down to chest wall and reflected the pectoralis minor. So the ability to do those kind of things, we're not training residents to do that anymore. I think it's going to be less of a problem in breast cancer where we will get away from X-ray dissection altogether. In terms of mastectomy, I think we still need to be training our residents to do that operation. There is pressure from plastic surgeons, and I don't mean this as a political statement, but to have a step aside and they'll do the mastectomy because they're still trained to do sort of subcutaneous and other mastectomies, which I consider actually inadequate for breast cancer control if you're not going to do breast preservation. So we've resisted that force. I think we still need to be training our general surgeons to do mastectomy. X-ray dissection, not so much for breast. But it does lead to this conundrum where the occasional patient who needs an X-ray dissection, and these are tougher X-ray dissections because patients who are still popping up with macroscopic failure that's refractory to treatment, to these weird isolated X-ray recurrences, and the medical oncologist comes to you and asks if you can take it out. Well, it's hard to do those operations if you haven't done a lot of standard X-ray dissections. So I do fear, and I don't know what the solution is, that we are training people who will not be able to do these operations in the future. So we'll be relying more on medical therapy, which may fail us. I do worry that there'll be a minority of patients where we lose X-ray control. I think this is a bigger issue for melanoma than for breast, because as I mentioned in the MSLT2 trial for melanoma, a lot of people came away saying, oh, that means we're not going to do X-ray dissection for melanoma anymore. But the trouble is you've got that 24% that fail. We don't know what impact immunotherapy will have for those patients, but if it doesn't control the axilla, and I'm already seeing patients where, based on the MSLT2, we didn't complete the X-ray dissection. The patient's immunotherapy didn't prevent recurrence. That non-sentinel disease did grow up, and now you're doing an X-ray dissection for macroscopic failure, which is refractory to systemic therapy. The trouble there is twofold. One, that's a harder operation, especially in someone who hasn't been trained to do it. And two, is it causes more lymphedema, because X-ray dissection for macroscopic disease causes more lymphedema, and it's associated with more morbidity than for microscopic disease. So on the one hand, it's good that we're getting away from routine X-ray dissection for both diseases. On the other hand, we're going to have this knowledge gap, and I don't know what we'll do about it. I'm hopeful that in the future the drugs will get better and better, and this will become a historical discussion. But there will be a period of time where I think this will be a problem. I recently wrote a chapter for Gray's Anatomy. There's a new clinical Gray's Anatomy that just came out on surgical techniques related to the Gray's Anatomy anatomic drawings. And what we did in this book was we used the classic drawings to explain how operations work and what's removed, what's not removed. And I wrote the chapter on X-ray dissection, and I had a funny feeling when I was writing it, who was I writing it for? But we'll see.
You're no different than a lot of us as open procedures go away, and the conundrum is how do we train the future generation of surgeons to be somewhat proficient in those. Well, let me gather your thoughts on a number of very specific breast conditions. The first one is inflammatory breast cancer, and I guess the diagnosis, is skin biopsy still valid?
It's still valid, but it often fails you. So just to back up, the amazing thing to me was that there are actually 3 questions on this topic in the CSAP 17, which is kind of amusing to me because I think this is one of those conditions that people tend to write more about than they see. Because inflammatory breast cancer only makes up about 1 to 5%, and that 5% is generous, of breast cancers. The key to remember about inflammatory breast cancer is it's a clinical diagnosis. So the 5%, I'll accept that if you say that includes any woman who comes in with some redness on the breast, pain, maybe a little peau d'orange, maybe history that redness didn't get better on antibiotics, and then finally someone did an imaging and a biopsy. So if you include those patients and you use that broad clinical diagnosis of inflammatory breast cancer, then I'll accept it. It makes about 5% of breast cancer. In terms of skin diagnosis, this point is made in one of the questions. In fact, the classic is you're supposed to do a skin biopsy, and it's supposed to show tumor cells in the dermal lymphatics. That's sort of the pathologic sine qua non of inflammatory breast cancer. But in fact, that's only seen in about 25% of patients. I've had a lot of patients where the skin biopsy just failed me, where I thought it was clinically inflammatory, the breast was red, they had all the other signs, but I couldn't prove it was in the dermal lymphatics. To me, it doesn't really matter. I don't bend over backwards to get a positive skin diagnosis. The real way to diagnose inflammatory cancer is clinically you say, okay, the breast is inflamed, there's redness, there's refractoriness to antibiotics, typically whatever. Then the imaging is done, and typically mammogram and ultrasound will find something that you can biopsy. And then the diagnosis is most commonly now made on a core biopsy that just shows any type of cancer. Often triple negative, but sometimes actually a luminal cancer, that tumor that expresses estrogen. So it can be across the board, but these tend to be more aggressive biologically. But the diagnosis is really based on the clinical findings and a biopsy showing any kind of breast cancer. So if you include that broad definition, then I'll accept it's about 5% of patients.
Okay, and has the treatment evolved? It used to be, didn't we just used to take the breast off?
Yeah, no, it's absolutely evolved. And back when we used to take the breast off, the results were always poor. Patients develop metastatic disease. In fact, about 30% have metastases at the time of diagnosis. And if you did an upfront mastectomy, the recurrence rates around the mastectomy flaps were high, and it was a very disappointing thing to see, and to realize you'd done essentially nothing with an upfront mastectomy. So nowadays, most of these patients are treated with what's called trimodality therapy. So they get their chemo up front. These tumors are often treated with adriamycin-based regimens, and taxanes are being added, and new drugs are being looked at as well, such as PARP inhibitors and other drugs that are on trial for these higher, more aggressive breast cancers, particularly if they're triple negative. And then if we can get a good clinical response, the redness goes away, the masses shrink, the PO improves, then, and especially if repeat imaging shows that there's been a clinical response, and we can go ahead and do an operation. There's nothing in CSAP about what operation to do because it's implied that it's usually a mastectomy. There's really no indication. It's rarely indicated for breast preservation. That would be the rare inflammatory patient that has that kind of response to chemo. Plus, theoretically, you're worried about leaving all that potential tumor stain behind. So if they do become operable, which is a lot of patients now, you would proceed with a mastectomy. I think that the proper answer in CSAP 17 is not to consider breast preservation, not to consider sentinel node biopsy. So this is still a remaining indication for axillary dissection, to get back to our other point. And then to go ahead and radiate the chest wall, because these patients have all the indications for radiation. They often have multiple positive nodes. They may have chest wall involvement initially. They've got skin involvement, which makes them T4. So they have all the indications for post-mastectomy radiation. So this is that trimodality therapy. And the 5-year survivals improved so that they're greater than 55% with this treatment, which is a lot better than 0, which is what we used to see. So that's sort of where we're at. I think that you can sort of dissect that a little bit more and realize that there are patients who are truly, truly bad inflammatory cancers with the positive skin biopsies with extensive inflammation, who are triple negative, who are younger. Those patients will be on the lower end of the survival numbers. There are patients where they're sort of inflammatory because they've got the clinical findings, but the skin biopsy is negative. The tumor may not be triple negative. It may actually be estrogen positive. Those patients will be on the higher end of that number. And those patients may actually go on to be long-term survivors and actually may end up on endocrine therapy if they're tumor sensitive. So they may actually get 4 modalities. They may actually go on to get hormone therapy as well and become long-term survivors. So again, it's a mixed bag, particularly if you use that broader definition of inflammatory.
Well, how about another one? How about occult breast cancer? What's our current definition of that, and What am I supposed to do about it when I see a patient with it?
So that's another thing that made me kind of smile when I saw the final version, because there are 2 questions on occult breast cancer. And this is another situation where occult breast cancers make up 1% of all breast cancers, so we're writing more than we're seeing it. And I'm also smiling because I'm guilty of writing one of those questions. And when I looked at the 2 questions on CSAP, I realized that they sort of, even though it wasn't a multiple-part question, they're separate questions in different parts of the text, but they actually sort of go together because they ask questions that sort of build on each other. So the first question says, how do you diagnose it? So the definition is a woman who comes in and she's got palpable axillary disease. You biopsy it. The biopsy shows malignancy, often actually shows breast cancer, maybe a ductal cancer, for example. And it may even be estrogen positive. But then you do a mammogram, and the mammogram is negative. So the first question on this in CSAP asks, well, what do you do for that? And the right answer is to get an MRI. Because, again, MRI is indicated for patients where there's a high suspicion, but in this case, the patient actually already has cancer, so definitely high risk. But mammogram has sort of failed you. So the right answer to that question is MRI. The second question says, okay, the MRI is negative, and that's the question I wrote. What do you do now? And we are seeing these patients. So nowadays, when we're seeing occult breast cancers, they're truly occult, meaning we really can't find the primary with even the best imaging. These are definitely, we're getting down to the 1% here, but that question is based on a real patient of mine who came in with exactly this picture and had a negative MRI. And the question becomes, well, what do you do? The old teaching that we taught our general surgeons was, well, you complete the mastectomy and you're going to find the cancer in 30 to 60% of cases on final pathology. But actually, that's not true anymore because MRI is weeding those patients out. So one of the answers to the question is, do you have to do the mastectomy? And the answer is no, you don't. There was a study from Korea where they actually put together 142 of these patients, which amazed me. And they looked at survival with surgery versus just radiating the breast, so doing an X-ray dissection and radiation. And what they found is that not doing the mastectomy, first of all, they found very low actual cancers in the mastectomy group, and lower than that, 30 to 60%. And secondly, found that not doing the mastectomy, just doing an X-ray dissection and radiating the breast had as good or better survival than doing the mastectomy. You know, that makes sense if you're not finding a primary in the breast and you're really not accomplishing anything with the mastectomy. The question remains, how can this happen? And the answer is twofold. Either the primary in the breast involuted after it went into the nodes, which has been known to happen, which is well described in melanoma, of course, and probably can happen in breast cancer rarely. The other possibility is that it looked like a breast cancer but actually came from somewhere else. And so some people think that so-called occult breast cancer is actually a subcategory of what are called carcinomas of unknown primary, where we don't actually know where the tumor came from. The other possibility, the third explanation, is that the tumor actually started in the nodes, that there are elements in the nodes that can look histologically like breast cancer. And this is one of the current explanations for melanoma of unknown primary, where patients pop up with nodes, but you can't find a skin primary. And if you think about it, if that's the case, if the tumor started in the nodes, then treating the nodes with either resection or radiation or endocrine therapy, if it happens to be endocrine positive, however you do that, you're actually treating the primary. So, of course, when you look at stage 3 breast cancer patients with a known primary versus stage 3 breast cancer with an unknown primary, the so-called occult breast cancer like we're talking about, some studies that will actually show that the occult patients do better because the nodes were the primary. And it's interesting because in the one of the CSAP questions, there's a reference to that literature. And there are a number of studies that actually show patients with occult primaries do better than if the primary is found. And that might be the explanation.
Well, how about another one? We've talked about it a couple of times already, but triple-negative breast cancer. What should that imply to the general surgeon?
So triple-negative breast cancer is something that I think the general surgeon should be very familiar with. It basically means, what we're basically talking about is a molecular subgroup of the cancer, and I've alluded to this before. So There are the so-called luminal cancers, which are estrogen positive. Luminal A is the classic good prognosis breast cancer in the older patient where it's estrogen positive, usually progesterone positive and HER2 negative. And that makes up about half of all breast cancers, fortunately. And those are the classic early stage older women who do well and may or may not need anything other than hormone therapy after their breast operation. Then there's luminal B where the estrogen is positive, but the HER2 is also positive, with or without progesterone positivity. That's a very small group of patients. The HER2 patients are patients who are only positive for HER2, and obviously they will see trastuzumab or other monoclonal antibodies against HER2 as part of their treatment. But then there's this group we used to call base. By the way, luminal, the word luminal comes from the luminal cells in the duct, which are the most common cells for breast cancer to arise. Most breast cancers, about 80% are ductal, and more than half of those are luminal, come from these luminal cells which line the breast ducts. But then there's this fourth category called basal. We call it basal, and the new term is triple negative. And these come from the basal cells that are deeper down in the duct. And these tumors have expressed none of this rate. They don't express estrogen, progesterone, or HER2. And at first you'd think, well, they don't express HER2, that's a good thing. But not expressing anything is a bad sign because, number one, you don't have a target for treatment. You can't give trastuzumab, you can't give hormone therapy. All you can give is chemotherapy. And secondly, it's a marker for an angrier cancer because when normal duct cells transform and become malignant, one of the things they do is they throw out or delete normal genes. So if they've deleted all three of these genes, that's a sign of an aggressive tumor. And indeed, when you look at these patients, their histology tends to be more aggressive. You see more medullary tumors, more grade 3 tumors, more secretory tumors, more adenoid tumors, and more inflammatory breast cancers, as I've already mentioned. So they are worse cancers. What's interesting about them is they're worse up front. So if you can get them under control with chemo and get them through the first 3 to 5 years without relapse, they actually have less later relapse. Whereas the luminal cancers, which we think of as good cancers, they are the patients who famously will relapse years later, which gets to the issue of do you really want to stop screening at age 75? But that's that issue. But I recently had a patient where I treated a luminal cancer, and it was a good prognosis luminal cancer, and I followed her for years, and to the point where we both felt a little foolish for following her. But sure enough, she developed metastatic disease and actually died of the breast cancer like 18, 20 years later. So these luminal cancers are sort of like melanoma in the sense that they can occur late, whereas the triple negatives, they have a higher mortality, but it seems to be early. And if you can control them with chemo and then some kind of operation and then often post-op radiation with that trimodality therapy we talked about, then they actually will fail less later. So you could get long-term survivors from these patients. Triple-negative patients have been the focus of neoadjuvant studies because, of course, chemotherapy is the mainstay for these patients because you can't give hormone therapy, you can't give monoclonal antibodies for HER2. The other reason they've been a focus recently is because they're more common in, as I already mentioned, in non-white women, in Black and Latino women, which is a biologic issue. It's not an access to care issue. We don't know why that is the case. And the other reason a third reason that we're talking more about triple negative is they have a high association with BRCA1. So it's long been known that if you're a BRCA1 carrier, you not only have a higher risk of breast cancer, but you have a higher risk of worse breast cancers. And that's because that population is at risk for triple negatives. On the other hand, I'll just mention parenthetically that BRCA2, while it increases risk for male breast cancer, it doesn't seem to increase risk for more aggressive cancers. So I think triple negative cancers represent an interesting group of women, of patients. They're more often women of color. They're more often inflammatory breast cancers. They're more often BRCA1 carriers. So there's sort of a last frontier for breast cancer. It's something we need to really dig into and go after. And there have been, last few years have brought in a lot of progress with looking at newer drugs. I've mentioned adding taxanes. I've mentioned adding PARP inhibitors and other newer drugs, and always focusing on neoadjuvant approaches because that way you find out if the drugs work. So one of the advantages of neoadjuvant, and this is important for general surgeons to realize, to sort of stay your hand, don't jump into the operation. Get your medical oncologist involved early. you will be doing an operation, but you might be doing it 4 months later. You get to put in a port, so you get to do 2 procedures instead of 1. You can look at it that way. But the point is get the medical oncologist involved early, get the chemo up front, and then you get what's called a biologic test. You actually see in the patient if the drugs are working, whereas you don't know that if you give them after surgery.
Are they not associated with younger age as well?
Yes, they're associated with younger age in the way that probably through BRCA.
Okay.
Yes, indeed, that's a good point.
Well, now, we've sidetracked genetic issues, but let's go right at them this time. So you've mentioned BRCA, and when you're treating a BRCA-positive patient, how does your management differ? Do you go right to that mastectomy?
Well, we used to. So I think it's important. What I think general surgeons should know is that when they first heard about BRCA1, they were told, or BRCA, they were told that those patients have an 85% risk of breast cancer. And when you hear that, you think, oh my gosh, everybody's got to have an upfront risk-reducing mastectomy. And that was sort of what was going on in the Angelina Jolie era. Those were the numbers, and it was a very frightening number. And the numbers are still frightening, but the point is that they're actually less. So as we've done more testing for BRCA1 and 2, and as we're finding more older women whose life expectancy isn't as long as populations that are rich for younger women, the assessments of lifetime risk for breast cancer and BRCA carriers has actually gone down. And there's a CSAP advanced question that actually addresses this. And the new numbers are that for BRCA1, the lifetime risk is 57 to 65%, and for BRCA2, the lifetime risk is 45 to 49%. So for BRCA2, it becomes basically a coin toss. Those numbers are still very high, but they're not 85%. So when women and providers hear those newer numbers, they're more inclined, if the woman says, I really don't want this morbid operation, I really don't want my breast removed right now, then I think we're more inclined to say, okay, we'll just follow you closely. How they followed? Well, again, the ACS recommends mammogram and MRI for these higher risk patients. So we're following them with MRI as well as mammogram. And we're now calculating what we call mastectomy-free years. So I have a woman in Alaska who comes down and sees me on a regular basis. We're doing MRI as well as mammogram screening. And we've had a couple of scares, but at the present time, I think she's about 12 or 15 years mastectomy-free. She learned about this from her sister who had breast cancer. She was tested, found to be a carrier. She was in her late 30s. Now she's in her mid-50s and has managed to be mastectomy-free. Now, we all agree that when something occurs, we'll jump on it and we'll think about bilateral mastectomy at that point. But again, those are smaller operations in the sense that you can spare skin, you can spare nipple. They're often sentinel node negatives. It's controversial whether you even need to do a sentinel node on those patients if you don't have a target. So the mastectomies are actually simpler because you're not operating for cancer, and they look nicer. They're cosmetically more appealing. So when we do pull the trigger on the mastectomy, you can still get a nice risk reduction procedure. But we do have patients that are actually choosing to go without mastectomy. They still need their ovaries out, that's for sure, because the lifetime risk for ovarian cancer, especially with BRCA1, remains 12%. And because you can't really screen ovarian because it's typically found later, we are recommending that they have their ovaries out when they're past childbearing. So what we'll do with these patients who choose to not have mastectomy is we'll get the ovaries out after age 35, and then we'll follow them after that with MRI. There's a 50% chance some of these patients will never come to mastectomy. And so that's sort of some new thinking. The other thinking that I think is not in CSAP is if we diagnose very early stage cancer like a DCIS or something, and the woman still doesn't want to pull the trigger on a bilateral operation, I don't think it's contraindicated to do lumpectomy and to follow that patient. You don't lose anything as long as you're following her closely. The CSAP advanced question goes on to talk about lifetime risk of breast cancer based on the gene mutation. So we've gone way beyond BRCA now, and we found a number of genes. We can talk about them if you want. They're not in CSAP 17 because we thought that was beyond the knowledge that a general surgeon needs to know. But the point that the advanced question makes, which is the simple point I'll make, is that when you line up all these other genes, the lifetime risk for breast cancer that they're associated with depends on their penetrance. And penetrance, of course, is the relationship between patients who express a gene versus patients who actually get the disease. And as the penetrance falls, we're less likely to recommend prophylactic operations. There are actually some genes that look like they should be associated with breast cancer risk, but in practicality they're not, and we're not currently recommending prophylactic operations for some of those lower risk genes.
Well, let me ask you about you mentioned genetic testing a few times, and there are a few questions in CSAP 17 on this. So you've got a patient with invasive breast cancer. Do they all get genetic profiling with one of these tests, either to predict recurrence or however you would use them?
Yeah, so let's define the term genetics. So there's gene testing that is done now with, we used to do gene sequencing, and then if a gene-specific mutation was known, we do mutation testing. A lot of gene testing is now done in panel testing. There are companies that create panels for different cancers we can get. And those are genes that predict risk. But I think what we're talking about now is once you've got a diagnosis of breast cancer, you can use gene panels to look at the risk for recurrence of that cancer. And do you need to add chemotherapy to the mix? You're absolutely right. There are questions in both CSAP and CSAP Advanced on this topic. And what they're really drilling down to is a test called, and I'll just mention it, Oncotype DX, which is a 21-gene expression profile, and then there's another test called MammaPrint, which is a 70-gene expression profile. And these fit into a broad category. I've already mentioned them, called genetic expression profiles, or GEPs. And what they are is you read the literature, find out what genes seem to predict for a certain outcome, for a certain disease, in this case breast cancer. Then you create a panel of those genes. You take the tumor, not the patient. Genetic testing, of course, they're testing the patient, but we're testing the tumor to determine the tumor's genetic potential. You take the tumor, you extract mRNA, use reverse transcriptase, PCR, to grow up the DNA that gave rise to that RNA, and then look at the expression of that DNA compared to a panel and compared to some normal genes. And you end up with what's called a gene expression profile, which shows you whether genes are underexpressed, overexpressed, amplified, whatever. And that kind of gives you a snapshot of how, as I tell patients, how angry or not angry the tumor is. I don't know if those are the right terms, but that kind of gives a patient the idea. That's what you're looking at. You're drilling down genetically to actually see the tumor's potential to metastasize. So for invasive cancers, we use but the most commonly used test is the Oncotype DX. As I mentioned, it's a 21-gene panel. And this test has level 1 data behind it. It asks, I think, the key question, because remember, most breast cancers are going to be luminal cancers. They're going to be ER positive. They're often luminal A, PR positive, and HER2 negative. So these are these cancers that should perform well. The reason we developed the GEP, the Oncotype test, is because the NSABP data, the prospective data, was conflicting. We ran the B14, and the B14 said, these luminal A cancers have a very low chance of relapse. But then we ran the B20, and the B20 said, most of these women get tamoxifen, but if you add chemotherapy, their relapse-free survival goes to almost 90%. So let's add chemotherapy. So that was two conflicting studies that came out of the same cooperative group. So the test was developed to say, let's get smarter and look at the tumor's genetic potential and figure out whether we really need to add chemotherapy by risk stratifying the tumors. We used to do that with a online assessment tool called Chemotherapy Online, which was based on a lot of retrospective data. And we also used to do it with the Nottingham score, but the Nottingham score uses size, and size is more a surrogate of time to diagnosis. It's not necessarily a surrogate for aggressive or non-aggressive biology, because a lot of non-aggressive tumors are big, like DCIS, for example. So anyway, the Oncotype score runs from 0 to 100. Less than 18 is considered low risk. More than 31 is considered high risk. And in between those is considered intermediate. And the thinking that came out when we reanalyzed the B20 based on, so first it was a retrospective analysis. They took the B20 data. But fortunately, they still had a lot of those tumor blocks. So one of the good things about breast cancer trials in the United States is they usually require we collect the tissue blocks. So they went backwards on the tissue blocks, ran the test, and what they found was that If you were low risk, there was no benefit for chemo in the B20. If you were higher risk, those were the patients that seemed to benefit. So instead of making a blanket statement like the NSABP made for DCIS, we're making a more genetic, smarter statement saying, okay, here are the patients who needed the chemo. Here are the patients who didn't need the chemo. If you're intermediate, the test doesn't really add much, unfortunately.
That was my next question, because I'm sure our audience is wanting to know, okay, so you have an intermediate patient. How does the discussion go?
At that point, the GP has basically failed you. So you have to fall back on, I hate to say it, but on the old chemo online and the Nottingham score and all the other clinical and histologic data you have, plus a patient's performance status. And then have a frank discussion and say, well, the best estimate is that chemo will increase your survival by 6% or whatever it is. In some patients, and then you have to let the patient, it's the platinum rule, you have to let the patient decide based on their goals. So you do what's right for the patient. And the patient may say, 6%, are you nuts? Or they may say, oh my God, 6%, I want my 6%. So let the patient decide. And oftentimes it's a stepwise decision. Start the treatment, see how it goes. You can always, bail out if there's toxicity issues that build up. The right thing to do, I think, with those patients, though, is to put them on a clinical trial whenever possible. And the clinical trial that's ongoing, it's been a trial that's been going on for a long time. It's a TAILOR-RX trial. It stands for Trial Assigning Individualized Options for Treatment. I like that. And what they're doing is, it's clear that if your score is less than 10, you should just go on endocrine therapy. Only all the prior data shows that. If your score is higher, no greater than 25, those patients are going on chemo. But what the trial does is, if you have an intermediate score, and they define intermediate a little differently. They define it as 11 to 25. But the way they define it, and I don't really understand this, but the way they define it, 2/3 of patients are being called intermediate. And I think that's because the trial's enriched for intermediate patients. I think actually that's what's going on. So in this trial, 2/3 of patients entering will be called intermediate and will be randomized to get the endocrine or chemo. Obviously, these have to be good performance patients who can be treated with chemo if they randomize to it. I think it's sort of the key question, and that'll allow us to drill down a little bit more into the score and figure out, okay, what does an intermediate score mean? So stay tuned for that one, but I think that's evolving.
We've talked a lot about surgery, a lot about chemo. We've touched a little bit on hormonal therapy. So I've got a patient for you. Let's say you've got a 50-year-old patient, has DCIS, negative axilla, and has her breast preservation surgery and has her 2-millimeter margins. Do they get hormonal therapy? And more importantly, if they do, how long?
Yeah, the current, as you know, these guidelines come out for the breast trialists every few years, and they're published. The senior author is Dr. Peto, P-E-T-O, so these are sometimes called the Peto recommendations or the Peto trials. They're also called the early breast trialist trials. They're usually published in the New England Journal. And the most recent data suggests that 10 years of hormone therapy is actually better than 5. So we warn patients up front that if they start hormone therapy, they may be on it for a longer period of time than the traditional 5 years. So that's the current recommendation for extent. In terms of who gets it, there have been some trials looking at this. And the question is really, can you eliminate some of the treatment in older patients? And the trials actually, there was a large CLGB trial where they looked at women who were older than 70. These were T1 patients that were ER positive. So again, these luminal A patients we're talking about, and these better prognosis patients. And actually they got hormone therapy in both arms because it was generally so well tolerated. And the question that trial asked was, well, you really need the radiation. So could you eliminate the radiation for these early but invasive patients? And what they saw was they saw more local recurrence, but the local recurrence could be treated in some cases with just a redo lumpectomy, in some extreme cases with a completion mastectomy, but as I say, we're getting away from that whenever possible. So we are starting to redo lumpectomies, which I'm happy to see, because I think the blanket statement that if you occurred in the breast after radiation, you had to have a mastectomy is gone. So, but the survival between the hormone therapy and the hormone therapy plus radiation was exactly the same. So In older patients, we're starting to think about dropping out the radiation. To answer your question, for the hormone therapy, assuming the DCIS is ER positive, not all DCIS is, but most of it is, it really depends on the woman's goals and her performance status and her age. Because remember, the P01 and the P02 trials, the prevention trials that were done by the NSABP, showed a significant reduction in risk for women with high-risk lesions like LCIS and high Gale scores. So the highest risk women among those patients are patients with DCIS. So if the patient has a good performance status and their tumor is ER positive and they want to keep broke breasts, they want to continue screening, then it makes sense to put them on tamoxifen if they don't have a contraindication. Of course, the issues with tamoxifen, and tamoxifen does improve overall survival by 31% for invasive cancer. The downside, of course, is there's a risk of VTEs. It's about 200,000 patients will have a VTE, a fatal VTE. So that's something that's rare, but it opens your eyes a little bit. And there are the famous menopausal hot flash symptoms. The ATTACK trial, which was a subject of the last CSAP, was a trial where women, not with DCIS, but with early-stage hormone-positive cancer, and it stood for anastrozole or tamoxifen alone or a combination. The ATTACK trial showed that anastrozole or aromatase inhibitor had about a 10% improvement over tamoxifen, which translated in a 3% overall absolute risk of recurrence. The trouble, of course, with aromatase inhibitors, you have to do monitoring of bone density. There's a 3% chance of a major fracture at 5 years. There's myalgias. You have to watch the lipid profiles. So you really have to look at, for older women who may have a contraindication to hormone therapy and for DCIS patients who, again, you drill down into what kind of DCIS you have, you kind of have to think twice about whether they really need the hormone therapy. And again, it's a team sport. What I'll do is I'll consult my medical oncologist and ask them, because frankly, if the patient decides they want to go on hormone therapy, I want someone else monitoring the side effects, particularly if it's an AI, because someone has to be ordering routine DEXA scans for bone density. They have to be starting bisphosphonates if there's a problem. They have to be watching the lipid profiles. That's something that I think a lot of surgeons should be asking their medical oncologists to help them with, because these are not benign drugs.
Well, John, I don't know where the time has gone, but it looks like our time is about up. And I just really want to thank you for sitting down with me today and talking about these things. And as usual, you've done an excellent job. You've actually anticipated some of the questions in some of the areas, didn't even give me a chance to ask the question. But we got the meat of the matter covered, I believe. So I thank you very much. And I also thank you for bringing up CSAP Advanced, which we're going to introduce at the Clinical Congress. So any last words about CSAP for our audience from somebody who's done it a few times?
First of all, John, I want to be sure to thank you for giving me this opportunity. You know, as I mentioned, I've written for a lot of these, somewhat to my family's chagrin, because it's a lot of work. But it is so rewarding in so many ways. It really keeps me on my toes. It keeps me checking all my facts and on the literature, which is why I love going to tumor boards, which is why I love working on CSAP. It's why I love to be in academics, because we have a responsibility to keep our colleagues in general surgery informed of changes in this field. And, of course, breast cancer is an area that frightens a lot of people because it changes so fast. And it is an area where we have to be aware of those changes. So it's a pleasure and a privilege for me to work with you to keep general surgeons informed of these changes. One of the things we love about CSAP is it comes out every 3 years, so we have to not go with fads or fancies, but actually go with solid changes that we think will continue to be important for the general surgeon to know through the cycles. So I just wanted to say it's a privilege to do this work, and I thank you, John, and the rest of the CSAP team and the college for allowing me that privilege.
Well, we thank you, too, and you have a nice day, okay?
We'll do it. You too, John.
That's it for this category of the CSAP 17 audio companion.